Hello everyone, here we start with the ABIM Master Review. In this course, I'm going to summarize all the high-yield questions and how they can come up in the exam. So we'll start with allergy and immunology. Okay, so what would be the first, we'll talk about the case scenarios that could possible. They can bring 31-year-old female, had a bee sting, and then developed respiratory distress, required intubations, right? Developed RDS, intubation. What to do next before discharge? Okay. So what could be the answer for that? The answer is refer to immunotherapy, so that they know what caused the anaphylaxis, so that doesn't happen again. All right. The second case is that you see a 36-year-old man with 3 episodes of sinusitis, okay, and they could bring you all the vital signs, the sinus tender to palpation, but somebody who have 3 episodes of sinusitis, what disease could cause that? It's usually common variable immunodeficiency. Okay, it can cause recurrent infections, bronchiectasis, vitiligo, rheumatoid arthritis, irritable bowel syndrome, increased risk for malignancy, lymphoma, causes low IgG, low IgA, low IgM, no response to vaccinations, that's another thing. And then the treatment, you do immunoglobulin replacement therapy, age appropriate cancer screening, and monitoring for lymphoma. Okay, so that's the idea. Okay, another case, you will see somebody came in, 39-year-old woman, came in with a pleuritic, chest pain, heart rate is like 114, blood pressure is elevated. What do you think could be causing that? Hypoxia as well, like pulse oxidate bring it, O2 is like 91%. What could be causing that? What is the diagnostic approach? Like best next step you would do? Do you give contrast? You don't give contrast? Then in this case, you would do CT. This is important because it's applicable. PE, angiography without precaution. You wanna do CT without precaution, with contrast. Use contrast. It's very important to diagnose in this case. All right, so now we get another case. Let's say another scenario they can bring. Let's say 40-year-old woman came in with a chronic rhinorrhea and post-nasal drip. They can throw in itchy eyes as well. And they tell you what is the management for this patient. So whenever they say the chronic rhinorrhea and itchy eye, this is most likely allergic rhinitis. So the treatment for that is nasal corticosteroid. That would be the best option here. Alright, so now another case is also important, where they tell you that somebody came in, like 60-year-old, came in with acute pancreatitis plus bilateral enlargement of parotid glands. Eosinophil would be elevated as well, like let's say 8% or so. What would be your diagnosis? This is like there's only one diagnosis that causes parotid gland enlargement, pancreatitis, elevated eosinophil. What would be your diagnosis? Diagnosis in this case, IgG4 related disorder. So this one is like IgG4 related disorder. It's an it's an autoimmune type 1 autoimmune pancreatitis, causes generalized lymphadenopathy. Other features that can present: sclerosing cholangitis could cause that, cause bilateral salivary and lacrimal involvement without significant symptoms like dry mouth, dry eyes. Thyroid disease, Hashimoto's, interstitial pneumonitis, pulmonary pseudotumor, tubular interstitial nephritis, retroperitoneal fibrosis. And the way you diagnose that disorder, you check for tissue infiltration of mainly IgG4 positive plasma cells and small lymphocytes. You have elevated IgG4 level, peripheral eosinophilia, and the treatment is immunosuppression with glucocorticoid. That's how you treat it. So an autoimmune, just like any autoimmune disease. Okay. Another case that is very high yield as well, you will see usually patient like 18-year-old female came in with who took amoxicillin and developed red bumps several days later, and then tell you what's the next step. Now she needs antibiotic. Now she's having some concern, either gonorrhea or something, anything, like, you know, like let's say came in with gonorrhea, present with gonorrhea, and then history, she took up amoxicillin. So do you give her Rocephin or not? That's a question they ask you. So here you gotta know things. You gotta know a few things. So if you have rash after antibiotics, this is very important. You always encounter that in clinical practice. So they will test you about it. If the rash after the initiating antibiotic was immediate, within hours, cause urticaria, bronchospasm, angioedema, then in this case, you stop the antibiotics and then you avoid the antibiotic forever. You don't give it, do allergy evaluation, okay? Don't give the antibiotic. But if it was delayed, like several days, it's likely it's non-IgE mediated, okay? And if there is just maculopapular rash, then could be drug viral interaction or viral xanthem. Most common diagnosis usually 7 to 10 days. So in this case, you just continue antibiotic and you can re-administer in the future, okay? But another case scenario, if they develop like serum sickness-like reaction, like fever, joint pain, targetoid lesion, lymphadenopathy with eosinophilia, what we call DRESS syndrome. If they develop any of that, then you stop antibiotic. You try not to do allergy evaluation, okay? Then that would be a very important high-yield question they will ask you about. Another high-yield question that they would ask, they will tell you, okay, 26-year-old woman with IgA deficiency, okay? And then they will tell you what transfusion you give. This is another high-yield question. So what transfusion you would do? In this case, you do washed red cells. Okay, so this is like a topic for the when do you do each transfusion. You do washed red cell also if there is complement dependent autoimmune hemolytic anemia, if there is continued allergic reaction, hives with the red cell transfusion despite antihistamine therapy treatment. This is washed, okay? When do you do leukoreduced transfusion? Leukoreduced you do in CMV, seronegative, at-risk patients, AIDS transplant patients, potential transplant recipient, previous febrile non-hemolytic transfusion reaction, clinically transfused patients, you do that. When do you do irradiated? Irradiated if there is bone marrow transplant recipient, acquired or congenital cellular immunodeficiency, if there is a blood component donated by first or second degree relatives, okay? These cases you would do transfusions. This is the type when do you do each one of them, okay? And that concludes the summary of the allergy and immunology. Thank you so much for listening.